Thanks, Dr. Sabella, and welcome back. This is the best part of the day because we just had our lunch. So, it's a 5-month-old infant who came into the clinic for the routine visit for immunization. Mom has concerns regarding poor eye contact, and he seems to startle easily. A true statement regarding his condition is physical examination may show hypertonia. He is at risk of developing seizures. He is likely to have normal developmental milestones. Specific treatment is available to halt the progression of the disease, or E, his condition is likely to spontaneously improve. And that's the fundoscopic finding. And the correct statement is at risk of developing seizure disorder. And the diagnosis, based on the history and the startling and the finding of the cherry red spot on the fundoscopic examination, is Tay-Sachs disease. Clinical findings in Tay-Sachs is usually they do not have any hepatosplenomegaly, and it is due to the deficiency of the enzyme. It's an autosomal recessive condition, autosomal recessive disorder. Characterized by the deficiency of the hexaminidase A gene deficiency. It causes the deposition of the glycolipids and the gangliosides in the cell lysozymes. Normally, the patients develop normally until the age of about 4 to 5 months, and then they do have neurodegenerative signs where they lose the milestones. They have decreased eye response and increased startle reflex, and the diagnosis can be made by the measuring the beta hexaminidase levels in the white blood cells and by the DNA testing. So next question, a 3-year-old presents with recent weight gain, poor appetite, breathlessness, and abdominal discomfort. He was seen in the clinic for URI 1 week ago. Which of the following is true regarding idiopathic nephrotic syndrome? A, hypertension is common at presentation. B, long-term diuretic therapy is beneficial. C, renal biopsy is indicated in all the cases. D, urine analysis shows microscopic hematuria. Or E, relapse occurs infrequently. And that's the picture on the left-hand side. Okay, so the answer was E, and the diagnosis in this was nephrotic syndrome. So I'll go through the choices. Idiopathic nephrotic syndrome, usually the hypertension is less common, and they usually, majority of them resolve, so they don't need really long-term diuretic therapy. And if it's idiopathic nephrotic syndrome, renal biopsy is usually not indicated. So once you confirm clinically, you can start the steroids and see how they respond, unless they are below 1 year old or more than 10 years old, or if they have significant hypertension on presentation or gross microscopic hematuria. Those are all the indications for, or having low complements, those are all the indications for doing renal biopsy at presentation. If they present with any abdominal pain, we need to make sure the child does not have peritonitis or renal vein thrombosis. That's one of the dreaded complications with nephrotic syndrome. And it's most commonest between 2 to 6 years of age, characterized by proteinuria, hypoalbuminemia, edema, and hyperlipidemia. 90% of them, they respond very well to steroids, and you can use cyclophosphamide as a second-line agent. A A 12-year-old young man with sickle cell disease presents with acute abdomen, fever, lethargy, cool extremities. All of the following are true regarding this diagnosis and management, except he may have cholecystitis. He should receive isotonic fluids to maintain IV hydration. His symptoms could be due to acute splenic sequestration. He should receive broad spectrum IV antibiotics after cultures are drawn, or he should receive intravenous narcotic analgesics. Good job. So usually the patients with sickle cell crisis, they do undergo autosplenectomy by the age of about 4 to 5 years. Hence, the C is the right answer. Sickle cell disease, they can have splenic dysfunction, and they presented with infections with capsulated organisms like Haemophilus influenza or streptococcal infection. Cardiomegaly, usually due to cardiomyopathy and also due to iron overload in the countries where they do a lot of blood cell transfusions for managing sickle cell disease is a major issue. Majority of the patients develop renal dysfunction due to the tubular injury, and they usually they undergo hypostenuria, especially if they are more than 5 years age. If you do a urine specific gravity, it's usually less than 10 in them. They have associated zinc and folate deficiency usually. Okay. The next question is a 2-year-old toddler with failure to thrive, diarrhea, irritability, abdominal distension, gained weight normally for the first 6 to 8 months of life and has subsequently not gaining weight. Which of the following is true regarding her condition? A sweat chloride test is diagnostic. A prolonged course of metronidazole is necessary. Requires specialized diet until adolescent growth spurt. Increased risk of developing lymphoma. Majority of the children with this condition will develop precocious puberty. We have a couple of pictures. You can see an emaciated child, and that's the biopsy findings. Yeah, 50% got it right. So the diagnosis was celiac disease in this, and there is increased risk of developing malignancy, mainly lymphoma of the small bowel. So celiac disease, as it was discussed this morning, it's a gluten-sensitive enteropathy. It presents usually after 6 months to 2 years. It's usually oats are not the problem, wheat, rye, barley. Diagnosis is by measuring the TTG. It's usually IgA sensitive, and you can also do the biopsy. And before doing the biopsy, we need to make sure they have been on gluten-containing diet for at least 6 weeks. Celiac disease can manifest in a variety of other ways like growth retardation, failure to thrive, diarrhea, vomiting, or muscle wasting. And the treatment option is gluten-free diet for lifelong. And you can also need to remember about the genetic marker HLA-DQ2 and DQ8. And if you are in the facilities where you cannot do a biopsy, and if you have the TTG levels that's at least more than 10 times the normal of your lab value, and the symptoms get better on putting on gluten-free diet, and you have positive endomysial antibody and positive genetic screening, you can avoid the biopsy in those scenarios. So this young man with history of asthma and eczema presents to the clinic with worsening eczema. On examination, he looks toxic, febrile, and has poor peripheral perfusion. The next best step in its management is refer to derm, IV methylpred, topical steroids with topical antibiotics, hospitalization for intravenous fluids and acyclovir and antibiotics. Awesome. So the diagnosis is eczema herpeticum. Its majority of the cases are due to herpes simplex, and it presents with intense pain and fever, and treatment is usually systemic acyclovir, and they are at increased risk of secondary bacterial infection, and we usually cover them with antibiotics too. Next question. A parent of a 10-year-old boy noticed that he has been limping for a few days. On further questioning, he had no pain while walking. Which of the following is true regarding his condition? He is at risk of developing hip osteoarthritis if left untreated. He is more common in girls. Affected children may have advanced bone age. Surgical treatment is always necessary. It's almost unilateral condition. We have the X-ray on the left-hand side. So there is a difference between the right hip joint and the left hip joint. Okay. So the diagnosis in this was like Calvé-Perthes disease or avascular necrosis of the left hip joint. If the choice was A, if left untreated, they are at risk of developing osteoarthritis. It's more common in boys. It's one of those conditions where it's common in boys than the girls. And because of the avascular necrosis, they usually have delayed bone age. And surgical treatment is not always necessary as long as you can maintain the femoral head in the hip joint. It can be managed conservatively too. And there are about 10 to 20% can be bilateral. And one of the other closest differential around 10 years of age is like slipped capital femoral epiphysis. But usually it happens in obese patient, and the X-ray finding would be different. You can have the dripping cone sign instead of the destruction of the femoral head. Some of the other findings are it can be associated with deficiency of protein C and protein S, and you can have avascular necrosis of the femoral head. Prolonged steroid use or trauma can be the other causes for avascular necrosis. A 5-year-old boy with history of malaise, fever, headache, nausea, and vomiting for the last 24 hours. He developed a rash an hour ago. Now he is lethargic, confused, combative. His heart rate is 160, blood pressure of 70/40. Blood work was obtained and an IV line is placed. The next most appropriate plan of action is to perform lumbar puncture, obtain urgent HCT, administer IV mannitol to reduce ICP, administer a saline bolus, or order ammonia levels. So the diagnosis in this vignette was meningococcemia because of the presentation and the development of the rash leading in shock. And the treatment of shock, the first line of treatment is to make sure the patient is hemodynamically stable with normal saline fluids. Performing a lumbar puncture, if it is meningococcemia, would not really make much of a difference because the duration of treatment is pretty much similar. But they are usually very coagulopathic, and you might in fact harm the patient if the patient is in DIC doing a lumbar puncture would be contraindicated right there. Okay. So there are some guidelines for the treatment of septic shock. The early goal-directed therapy, there have been a lot of papers to and fro in the last few years. But the rough rule of thumb is like make sure you have adequate preload, the CVP of about 8 to 10, maintain adequate MAPs of at least 60 to 65, make sure the patient is making enough urine, at least 0.5 ml per kilo per hour, and treat them with antibiotics. I think there is a paper that just came out this month which is going against all the recommendations of the early goal-directed therapy. So a 3-year-old toddler presents with recurrent ear infections and sinusitis is recovering from a recent bout of bacterial pneumonia. On examination, he has prominent blood vessels in the conjunctiva. The mother informs you that he has been unsteady on his feet for the last week. Which of the following is true regarding his condition? Serum immunoglobulin levels will be normal, reassuring that this is all part of growing up. A sweat chloride test would be diagnostic. Imaging of the brain will be normal, and the child has increased risk of developing malignant tumors. This is the right picture, and you can see dilation of the blood vessels in the conjunctiva. Okay, so the diagnosis in this vignette was ataxia telangiectasia. So the right answer was the child's at increased risk of developing malignant tumors. Ataxia telangiectasia, it's an autosomal recessive disorder where there's a deficiency of the ATM gene, and the function of the ATM gene is to detect the defective DNAs in the blood cells in the body. It can affect the neurological system, immunological system, endocrine. Serum IgA is usually absent, and there is decreased serum IgE, hence the first choice is absent. There is a high incidence of malignancies because of this defective DNA repair, and there is progressive cerebellar ataxia. If you do an MRI, they usually have cerebellar hypertrophy or cerebellar atrophy, and because of this IgA deficiency, they are more prone for the recurrent sinopulmonary infection. Okay, the next question is a 2-year-old who presents with abdominal mass, which has been noted by the mother while bathing him. Which of the following is true regarding the abdominal mass in this child? A laxative enema might be needed. Associated hypertension is very rare. The siblings have an increased risk of similar condition, and surgical management is rarely necessary. And in the picture, if you could try to focus on the pupils and see. So. Yeah, the answer was Wilms tumor, and there was aniridia in the picture. So Wilms tumor usually presents as a mass. It's an incidental finding, sometimes associated with hematuria, painless hematuria. If it is associated with aniridia, there are certain conditions we need to know. One's called the WAGR, Vagar syndrome, where it's Wilms tumor, aniridia, genitourinary malformations, and mental retardation. And there are also other conditions called Danish Drash syndrome, which is associated with Wilms tumor, and congenital nephrotic syndrome, and male pseudohermaphroditism. And it's also associated with Beckwith-Wiedemann syndrome, if you can have hemihypertrophy. It's usually a deletion of this WT1, WT2, WT2 gene in the region of around chromosome 11. And hypertension is a common manifestation. In majority of the patients undergo surgery with chemotherapy plus or minus radiotherapy. And siblings are at a high risk if there's a patient or a sibling, and if it is a genetic origin confirmed with the genetic testing, they do surveillance screening of the abdomen with the abdominal ultrasound every 3 to 6 months based on the age of the patient. An 8-month-old is seen with a 3-week history of diarrhea, abdominal distension, rectal prolapse, poor weight gain. Past medical history is significant for hospitalization for recurrent for staphylococcal pneumonia at the age of 3 months. The next most appropriate plan of action is to obtain an urgent surgical eval, obtain serum immunoglobulin levels, obtain serum antigliadin antibodies, change your milk to soy-based formula, perform a sweat chloride test. Excellent. The diagnosis in this vignette was cystic fibrosis. The incidence is based on the from where you are from, and it's an autosomal recessive condition where there's a defect in the CFTR gene in chromosome 7. It can involve the airway, the GI tract, the sweat glands, and the genitourinary system. Because of the involvement of the respiratory tract, they are usually more prone for respiratory infections, more likely like staph, and they're usually eventually colonized with Pseudomonas. With the GI manifestations, as it was discussed this morning, they have a lot of pancreatic issues where there's no reabsorption of the fat or the proteins that can give rise to failure to thrive, multiple vitamin deficiencies of the fat-soluble vitamins, and malnutrition. Meconium ileus can be an initial manifestation too. There are a lot of other atypical manifestations, including nasal polyps, rectal prolapse, isolated hepatobiliary disease. For the diagnosis, if you have a typical clinical history or a family history, and then you have a newborn screening, we do the immunoreactive trypsinogen. This is an enzyme that is released by the pancreas that can be detected in the newborn screening. And if that is positive, you confirm it with sweat chloride test, and you need to have at least 2 sweat chloride tests done separately. And the diagnosis can also be confirmed with CFTR gene analysis. There are false positive sweat tests. Some of the conditions are adrenal insufficiency, ectodermal dysplasia, hereditary nephrogenic diabetes insipidus, G6PD deficiency, hypothyroidism, and hypoparathyroidism. So the last one, the parents of a 6-month-old are concerned about sudden jerky movements of the whole body. She seems slow making her developmental milestones. She is not smiling, not able to roll over it. Which of the following is the true statement regarding her diagnosis? Her manifestations are likely due to perinatal asphyxia. She is at risk of developing heart failure or arrhythmia. The jerking movements are not likely to be seizures. She has inherited this condition from her mother. Okay, 58% got it right. The diagnosis in this vignette based on the clinical skin findings and the jerking movements of the whole body is tuberous sclerosis. So as we discussed, tuberous sclerosis is an autosomal dominant condition, but 80% of these cases are new mutations, or they are de novo mutations. It's got a widespread clinical spectrum. Many organ systems are involved. It can present with tumors in the brain. And the classical EEG finding is the ipsarrhythmia. It can also affect as tumors of the heart, especially in the newborn, called the rhabdomyoma. And it can present with heart failure or arrhythmias. And you have angiomyolipoma of the lungs that can lead to pneumothorax. And some of the diagnostic major criteria are the hypomelanotic macules. If you have more than 3, at least 5 millimeter in diameter. Thank you for your time and attention.